Hi guys, it's Janae with Daily Dental Hygiene, and today I'm going to be talking about one of the biggest questions I get, one of the most important things that you can be as a clinical hygienist, and that's being good at removing calculus. So this video is going to be a very extended video and a very detailed video about how to remove calculus, my tips and tricks, and how to be the best clinician that you can be. As a full disclosure, I truly believe that it doesn't matter if you've been doing this 20 years or 20 days. That doesn't mean that you're a good or a bad clinician. I know plenty of people that I've temped at and they've had their hygienist for 30 years and they leave calculus all over the place. And it's burnished and it's old and it's a crappy job. I know hygienists that are doing it that are great at it. I have been a hygienist for literally 1 year. And I feel like I'm pretty good at removing calculus, but I also keep my ego aside, I keep myself in check, and I am constantly focusing on growing as a clinician, knowing what areas I'm missing, and going back and educating myself on how I can be better. So if you're watching this video, you're already one step ahead because you clearly care about your clinical skills. So whether you're a hygienist of 20 years or you're a student watching this, stay tuned and you might just learn something new. So the first thing I do is I take checkup x-rays. When I take checkup x-rays on a patient, I look and see where all the calculus is. So many patients have their x-rays taken and the clinician looks at it and then immediately minimizes the video or the photos of their x-rays. Why? It literally just showed you a roadmap of every place you need to hit while you're cleaning your patient's teeth. When I'm cleaning and scaling, I make sure that I have my x-rays open of each section I'm at. Okay, I'm on the upper right and I have my photos of the upper right. I have my bite wings. It's like as I'm moving in their mouth, I'm also moving my roadmap so I see what I'm doing. It shows you where all the calculus is. It shows you the bone loss. It shows you the furcations. It shows you what you need to do. We don't have x-ray vision. I cannot see underneath the gum line. I rely on my x-rays in order to be able to see where it is I need to hit. So when I'm moving along with my cavitron and I see that I'm coming up on a spicule, what I do is I take my foot off the pedal. I use the tip of my cavitron to feel that spicule. Okay, I'm feeling the mesial of number 4. Yes, okay, I feel that spicule right there, right there. And then I hit my power and I engage with that spicule. I get right underneath the that piece of calculus and I pop it off. I freaking get in there and I blast it off. And then I go up and down, seesaw back and forth, kind of re-go over that area. And what I do is I then take my foot off the power again. I re-feel and explore with my cavitron tip. Okay, good, I got it. Or I'm gonna keep going. You know, I got half the piece off. So make sure that you're also using your cavitron to clinically detect calculus, and make sure that once you are feeling it, you then initiate your power so that you're not burnishing it. What happens is when you are on top of a piece, you burnish it down instead of getting underneath the piece and popping it up. Burnished calculus is absolute hell to remove, and this is why I'm making this video. I am so tired of cleaning off burnished calculus or calculus that has been there for time and time again. I'm so tired of taking checkup x-rays on your patients and other people's patients and pulling up the x-rays from 2019, 2018, 2017, and the same spicules are still there. Like, how are you missing those pieces 5 years, 6 years, 7 years? I mean, we're not perfect. Everyone misses pieces. But if you're seeing multiple radiographs where you're continually you're doing your patient a disservice and you're not actually getting the pieces, you need to start, figuring out what you're doing incorrectly. You need to start exploring and using some of my tips and tricks so that you're doing right by your patient, but also the other clinicians that might be seeing that patient as well. On top of it, once I'm done with my cavitron and I've used my x-rays to make sure that I really get everything well, I blow air on the areas that there was calculus, supracalculus. So the lower anteriors is a huge spot in which we will see calculus. That's how you can kind of gauge the overall health of someone's mouth. Right in there, you'll see those rings of calculus. Cavitron them off, scale them off, blow air. And before you even blow air, it's always nice to tell patients you're blowing air. blowing air in someone's face is very uncomfortable, especially if they have sensitivity or recession. So I say, okay, I'm gonna blow some air on the bottom teeth. When I blow air, this is going to help me see where all the calculus is left. Just like when you take a glass out of the dishwasher, there'll be minerals and water spots on it once it dries. Same with your teeth. When I blow air, I can kind of dry out the teeth and see where those minerals are still left behind. And then they think to themselves, wow, this clinician's very thorough. She's double checking her work. And I get patients that say that all the time. You're so thorough. You really double check your work. It's not that I'm doing anything differently that you might be doing. I just verbally tell my patients I'm doing it so that they know that I'm doing it. So blow air, scale those areas, blow air again, and keep scaling and reblowing air until you've seen that you've removed all that calculus. Another thing I do is I then explore. Once I've cavitron, once I've gone around and scaled, I then explore. So exploring is way different than scaling. When you scale, you are fulcruming, you have lateral pressure, you're pulling on an area. You're engaging with a piece. Exploring is the complete opposite. You need to have feather-like pressure when you're holding your explorer. You should be able to take your other hand and pull that explorer out and not have to lightly pull it out of your fingers. See, this is how I explain it to another clinician. If this is a tooth right here, and there's a spicule right here, that bump is a spicule. If you're using tight pressure, you're not allowing the vibrations to hit your fingertips for the tactile sensitivity. You're gripping down on it. You're not going to feel anything. So if this is a speed bump right here, a spicule, and you're gripping down on it, you're going to be like, oh, I'm the best clinician ever. I'm not missing anything. No, your pressure is way too hard. You should be dragging it lightly along the tooth. So light finger pressure, when you're dragging it, you'll hear that click, that bump. You'll feel that speed bump. That's how you know. That's how you know that you need to get in there better, because you've now just felt that like little speed bump. Another way to kind of describe this is, say I'm driving my car. You're driving your car. You have a string and a Coke can attached to the end of it. Now, if you're driving super fast, that Coke can's not even going to be touching the ground. It'll just be flying through the air. But if you put light gas on your car and you let that Coke can slowly drag behind your car, every bump, every rock, every divot, it's going to bounce up and down. Same thing with your Explorer, right? It's that Coke can. When you're light and you're going slow and you're feeling it gently, you're going to feel every bump and divot, every rock, every crevice, every speed bump, everything. You're going to feel it so much better. On top of it, once you go to floss your patient, this is a big one. People don't really know this one or really think about this. Floss is another really good way to explore your patient's mouth. What do we do with floss? We wrap it around each side of the tooth, seesaw it up and down, wrap it to the other side, seesaw it up and down. If you're bouncing it, you're missing an opportunity to really kind of explore one more time. And I do catch calculus all the time on a daily basis from using my floss as an explorer. So wrap it around the tooth, go up and down, and you'll feel that click. Floss is very thin, it's very fine. When it goes over a click, you'll feel it. And then when you go up and down, you'll feel that click. Sometimes it's hard because you don't know if you're hitting the CEJ or you're hitting a piece of calculus. One thing I like to mention is if you feel the click both ways, that's a piece of calculus. If you're going down and you're not feeling the piece, but you're coming up and feeling the piece, it's probably the CEJ, because the CEJ goes a little bit over the roots. So you'll feel that click coming up, but not necessarily going down. And also use your common sense. Look at the x-rays. When you're scaling an area, if you've scaled that area multiple times and you're still feeling it, it's probably the CEJ at that point. Another thing I do is post-op x-rays. When you're done with SRPs, please take post-op x-rays. I've seen so many times where people take their x-rays, diagnose SRPs, and then don't do post-op x-rays, and the patient comes back and we take x-rays a year later and all that calculus is exactly where it is. Calculus doesn't form within 3 months, black spicules like that. So if you're seeing that, it's because you're missing a lot of calculus. When I am taking post-op x-rays, if I see that I've missed anything, I take a piece of gauze, I take my instrument and I scale a couple strokes and I wipe it on my gauze and I check because I want to see that black, that brown, that dark colored piece of spicule on my gauze. I want to physically see that I remove that piece. And then I go back in and explore, I redo the gauze, I rescale until I see that piece on my gauze. Now, if it's a very, very tenacious piece and you're scaling and scaling and you're not getting it off, go back in with your cavitron. Go back in and make sure that you get in there, get underneath that piece and blast it up. Pop it up. Don't sand it down. Pop it up. You can tell when a piece has been burnished because they'll have done scaling and root planing or they'll scaled their mouth, but an area still has bleeding and inflammation and deep pocketing. It's because there's residual calculus left in there. And when you get in there and you scale, you wipe on your gauze and there's black calculus and you're like, we see this patient every 3 months. What the hell? Why is there black calculus in their mouth? Black calculus takes many, many days, weeks, months, years to form. So if you're seeing that, it's been there for a long time. Good thing you're getting it out. So please use these tips and tricks in order to remove calculus. It doesn't matter if you've been doing this 1,000 years or 1,000 seconds. I see people that are good and bad clinicians all the time, but it's all about putting your ego aside and taking the time. When you don't remove a piece of calculus in 3 months, you're gonna have to remove it then. And if you don't remove it then, you're gonna have to remove it in another 3 months. And every time that you don't remove that piece, it is becoming more and more tenacious. It is coming more and more mineralized. It will be harder and harder to get off every single time. I'm telling you this. Please make sure that you are actually taking all these tips and tricks to heart and triple, quadruple checking yourself. It's okay to miss calculus. Everybody misses calculus, but at least put your ego aside and make sure you're taking checkup x-rays and you're also taking post-op x-rays and doing all the tips and tricks so that you have multiple areas of catching where you're missing. When you pull up post-op x-rays, and you see patient after patient that you're missing a certain area, document that in your brain, educate yourself, and when you're cleaning someone's mouth, say, you know, every time I take post-ops, God, I always miss the distal of number 24. I don't know why I miss that one every time. Yeah, number 13 that's that one tooth, I do a bad job. And then every time you're subconsciously cleaning their mouth, make it, a mental note to clean that area extra well because you know you miss it every time. So use all these tips and tricks and be the best clinician that you can be. And I'm tired of seeing burnished calculus, so help me out. Bye.